So we've talked about vasospasm, we've talked about platelet plug formation when the platelets aggregate and plug damage to a blood vessel. Now the third step of blood clotting are the clotting cascades. So this is when we have these clotting factors, these proteins in the blood, which are made by the liver, circulating. When they get exposed to subendothelial collagen, different factors in the subendothelial collagen, just like platelets get exposed to von Willebrand's factor, which activates those, they form this cascade of events. So they activate one protein, which goes to the next, the next, the next, the next, the next. So that's called a cascade of events. And the end goal is to take fibrinogen, convert it into fibrin, and then fibrin, when it has factor 13 with it, it forms this stable fibrin clot, right? A patch of the blood vessel, right? And prevents further bleeding, right? Heals the blood vessel. Or if it's pathologic blood clotting, this forms intravascularly in an artery or vein, and then you form a clot or a thrombus, which is just protein. It's this fibrin protein. So let's see this here. So we have two pathways. We start with the intrinsic pathway. Factor 12 gets converted into 12A. So this is your intrinsic pathway. Then 11 gets converted into 11A. So these are all just clotting factors, proteins. Then 11A converts 9 into 9A. So this is my intrinsic pathway. So right, intrinsic pathway. Now my extrinsic pathway, so this starts with factor 5, 6, 7. Again, Roman numerals for everything, right? This becomes activated into 7A. Okay. Now, along with another factor, which is factor 8A, that gets activated as well. We don't need to talk about all the details of that. So these things are going to convert the common factor. So this is a lot simpler here. This is my extrinsic pathway, and we'll come back and talk about how we evaluate these with lab work. Extrinsic, I can spell. So then the common pathway, what these are going to do is they're going to convert factor 10. So 10 is our common factor, and this is going to convert 10 into 10A. All right, common factor. 10A is going to convert prothrombin. So this thing called prothrombin. So pro, it's not activated yet. Okay, so things that start with pro, like proinsulin, prothrombin, or if they end in ogen, like fibrinogen, plasminogen, they're inactive. It's a sign, they're a name that gives them that they're inactive. So 10A is going to convert prothrombin into thrombin. And what's thrombin going to do? Thrombin is going to convert fibrinogen. So again, another protein made by the liver, fibrinogen, ogen. It's not active. It ends in ogen. It's going to convert fibrinogen into fibrin. And then fibrin, along with factor 1, 2, 3, 13, forms a stable fibrin clot. So this gives us a stable fibrin clot. So stable fibrin clot. And fibrin is just a protein. Okay, or we call that, if that was an artery or vein, we call it a thrombus, right? If a piece breaks off, that's a embolus. And that's how the clotting cascades work. So, and different drugs are going to work here and affect these, and we use different labs. So to evaluate the intrinsic pathway, we look at APTT. That's your activated partial thromboplastin time. That's measured in a certain amount of seconds. And the extrinsic pathway, this is measured by PT, so prothrombin time, and your INR. And INR stands for International Normalization Ratio, if you ever wanted to know. And why they do that? Well, one of the earliest blood thinners was Coumadin, so warfarin. So warfarin blocks this pathway by being a vitamin K antagonist. So we need vitamin K to make a lot of these clotting factors. So if we antagonize vitamin K, that's very upstream, right? As blood thinners, so anticoagulants, you shouldn't say blood thinners, we talked about that. As anticoagulants got more advanced, we worked more downstream in the clotting cascade. So inhibiting or antagonizing vitamin K is very early on here. So when people on warfarin, like they had a target prothrombin time of 2 times or 2.5 times baseline or normal range, whether they had a valve replacement, or they had atrial fibrillation, whatever the reason was. And that was hard to look at those numbers because there's a range of prothrombin time. Where INR, we said, hey, let's make a normalization ratio, internationally normalized ratio of 1.0 being normal. So if your goal is 2 times the normal, well, your goal INR is 2.0, or your goal INR could be 2.5, or it could be 3.0. So quick lesson as to where that came from, okay? So these are the labs we use to evaluate these pathways, okay? Now, drugs that affect these pathways, well, intrinsic pathway, these are the heparins. So this would be, well, heparin, and low molecular weight heparins like Lovenox, which is enoxaparin. And then here, we just talked about this, so drugs that affect this, so warfarin. So warfarin, Coumadin, whatever name you want to use. And that's how we evaluate them. And those are some drugs that affect those pathways. Now, again, as we get deeper into the common pathway, this is the common factors 10 and common pathway. Well, there's factor 10 inhibitors like Xarelto. There's direct thrombin inhibitors. So as blood, or there's anticoagulants, right, have gotten more advanced, we've worked more downstream in the pathway closer to this, right, until the point of we have direct thrombin inhibitors, okay? We talked about antiplatelet drugs before, like aspirin and Plavix, which is clopidogrel. We'll come back and talk about those, but you can see all these ways we can either inhibit platelets with antiplatelet drugs, or we can use these anticoagulants, right? But again, these aren't making the blood thinner, they're just making the blood less likely to clot or take longer to clot. Okay, then once we have our stable fibrin clot, well, what happens once the blood vessel heals? We heal the wall up, we heal the endothelium up, so we've got vascular endothelial growth factor and all these growth factors that heal it up because we have inflammation that stimulates healing, all that stuff. Well, to break down the stable fibrin clot, our last thing here is plasminogen. So plasminogen, again, it ends in ogen, it gets activated into something called plasmin. And that's activated. So how do we activate plasmin? Something called T, little t, big P, big A. That's tissue plasminogen activator. So we have this enzyme that activates plasminogen into plasmin. And what does plasmin do? Plasmin will dissolve this fibrin clot. And that brings up another drug class, TPA. If you work in the ER, right? So the emergency department, the ED, they'll be like, hey, give the patient TPA, or it's we use a clot-busting drug. What's a clot-busting drug? Well, it's just TPA. It activates plasminogen into plasmin and will dissolve a blood clot. Think of a patient that has a DVT, right? That's just a fibrin clot, a thrombus. A piece breaks off, goes to inferior vena, or the deep veins of the leg, inferior vena cava, right atrium, right ventricle, into the pulmonary trunk, and blocks one, or if real bad scenario, both pulmonary arteries, like a saddle embolus. Well, you can give TPA and it'll hopefully bust that clot up and save your patient. But it does have a higher risk of bleeding. This isn't something that patients take on a day-to-day basis, okay? So this is how the clotting cascades work. So I know it's a lot, all this number and that number. It's really not as bad as you think if you look at it, but I think the most important thing is to understand there's two pathways, understanding what labs you use to evaluate these, right? Because if you have a patient on a heparin drip, you're going to be drawing a partial thromboplastin time every couple hours. If someone's on warfarin, you're going to be checking a PT-INR. Also, people with bleeding disorders, like if they have hemophilia, right, that's going to affect these clotting factors here, and they would have an elevated APTT. Or if someone has liver disease, like cirrhosis, well, it would affect some of the clotting factors made in the liver, and they could have an elevated PT and INR. So those are some things you're going to see down the road, okay? But knowing the common pathway is important, and then if you understand this, you know where these anticoagulants work, and the pharmacology isn't quite as bad, okay? So it's multiple drugs we talked about, right? Heparins and Lovenox, that's your heparin drugs, your warfarin drugs, your factor 10 inhibitors, your direct thrombin inhibitors, and TPA.